I feel like we're all on the same page here, which is wonderful. Between listening to Jackie earlier today and now listening to Jeff, and also to Alice, that physios are good listeners and we're good people, and we have to do a little bit more about that. So let me just elaborate a little bit. You can tell that I'm older than most of you in the room. In fact, I'm probably almost your grandmother, definitely your mother. And the fact that I'm still so excited about being a physiotherapist is definitely a good sign. It's a great profession. So even when I worked in this was the time when you could get jobs in hospitals and rehab centers, which would be nice if everybody could start off that way. But even when I worked in adult outpatients at Victoria Hospital in London, I was always the therapist who was interested in the patients behind the curtain. You know, everybody wanted to work with the guys in the gym. Now, I don't know if that's still the typical scenario, but the guys behind the curtain usually wanted to talk, or they were more involved, or we couldn't just quickly do so-and-so's exercises. You know, we had to listen a little bit. So I must admit that early on, and we're talking 79 to 82 when I worked at Victoria, I started creating sort of education programs because there was something missing in just being able to provide treatment versus really getting a patient to understand what was going on. So remember, this is long before we now have a pain science division, and this was no evidence, no guidelines, no nothing. And when I opened a private practice in 82, the main goal was because I needed to spend more time with people. And when you work in a hospital at that time, you really did not have enough time to speak with people. But as our moderator mentioned, it quickly became a place where people who had trauma, usually trauma, were not getting any help. This is in Ontario before any auto insurance legislation, before any real understanding of what rehab for pain patients was, etc. So very quickly, the people that were attracted to the clinic were those that, quotes, were not getting better. So right away, I was faced with people who were sometimes 2, 3, 4 longer post-trauma, and some people with medical conditions that were painful, but were not really making improvement. So the way that we didn't have these meetings nowadays. So for years, I was the lone physiotherapist who attended the International Association for the Study of Pain meetings, Canadian Pain Society meetings, and I can tell you that over the years there was an evolution in who's going to win, the psychologists or the physical medicine people. And over time, though, we realized, of course, that a multidisciplinary approach to pain is really what's necessary. So it's really exciting to see what's happening now. But for some of us who started off, we were really working in really a wasteland. Okay. So because I've always been concerned about the people who are not getting better, I guess I have to go to my first slide. No, that's my second slide. That's my second one. Okay. So when somebody comes to see me, I usually have to ask myself, why am I seeing this person? I mean, they've already had an injury a few years ago. What is still going on? They don't seem, like Jeff was saying, I mean, they don't have all those buzzwords. They're not psychologically overwhelmed. They like their job. They like their family. They want to get back to work. So why are they still here? And that was the premise of starting to listen a little differently. And I would agree with Jeff that listening is the most critical thing that we do. So if we just go back to what the word pain means, and I'm not giving a lecture on pain, but just to remind us that pain is just a sensation that says that something is wrong or something is going on that doesn't feel right. And it has emotional, and it has physical, and it has all sorts of other consequences. So as a physiotherapist, after I talk about this word, I never use this word again, because if I'm talking to a patient about their pain, I don't really know what they're talking about. I have to describe it, or they have to describe it, and we have to figure out what's the pathway to help them get better. So I start with this definition. I explain to people, asking them, so if you had to tell me what the word pain means, what does it mean? And usually answers are somewhat functional. It means that I can't work, it means this, it means that I have a headache all the time, until you start zeroing in on that. So certainly this whole idea of pain education has really been an integral part of what I've done, or pain management. But now you really think in terms of, is it just pain, or is there something else going on as well? Because the guy that's showing up in the clinic 3 years post-trauma, who has a good job to go back to and has tried several return to work programs and it hasn't worked, it's not the exercise. It's not that they're not trying hard. Perhaps there's something going on. And so I started to observe people. I mean, I've always been a good observer, but you observe more carefully, and you watch them in the waiting room. I'm always peeking out and seeing sometimes people are hanging on to furniture a little bit. Sometimes people arrive wearing ball caps, sometimes with sunglasses on. And my aha moment came. I mean, I've always been suspicious there's something else going on, but my aha moment came years ago when I was listening to Dr. William Padula speak, who's an optometrist, who was speaking at a big rehab conference at Parkwood on stroke rehab. And the aha moment was, well, yes, of course, there must be something going on with the visual system, because why else? Like, we've negated all the other things. And if we think about vision, it becomes center of gravity, it becomes memory, it becomes concentration, spatial awareness. People very often, who are trying hard to remember their exercises, don't remember their exercises, and you give them sheets of paper and you say, follow this, and sometimes they just can't follow those directions. So I started investigating the visual system more, and Dr. Padula is a founding member of the Neuro-Optometric Rehabilitation Association, NORA. Okay, and I would suggest that it's a good resource to go into NORA. In the States, I would suggest that we're probably a little bit ahead about recognizing possible post-trauma effects of vision issues. Not just the sports people, not just children with reading disabilities or learning disabilities. So the NORA gives you a checklist. And as a physiotherapist, I started using the checklist just to see, again, looking at other symptoms that are going on. This is half the NORA. So it's called a Rehabilitation Professionals Checklist. And if you check off enough of those boxes, which is really one or more, the diagnosis becomes one suspicious of post-trauma vision syndrome. And this is the other half of the chart. And if you check off more than one of those, it's the visual midline shift syndrome. Now, those of us, I was listening to Jackie this morning, and many of us have done vestibular courses, oculomotor courses, etc. I think we're sort of at a stage where you got to put all the little pieces together. It's not clear-cut exactly what's going on. So this is a questionnaire that I use that would at least start steering me into another direction. The other thing that I must admit that I use is to do, it's not the whole scan, but to look at the TMJ more carefully. I think there's a myth that the TMJ is somewhat innocuous, especially when you get into chronic post-traumatic, persistent post-traumatic problems. We're trying to change the idea of chronic sounds like, remember, chronic pain is not a diagnosis, it's a symptom. All right, so it's a symptom. So don't diagnose someone with chronic pain. Say they may have chronic pain because they have a back problem or chronic pain because they have a headache, but it is not a standalone diagnosis. And unfortunately, it's still used that way. It's still generically used as, quotes, they have chronic pain. And of course, many of the people that I saw were already labeled. You have chronic pain, you got to learn to cope with it, get back to work hard, etc., etc. You're looking at something like trauma, and I'm not saying it's the only area that you would look at, but if you look at trauma, you have to say what else could have happened at the time of the accident, whatever it was, or the fall. right? Somebody hurt their neck or their back or their shoulder, but maybe they suffered a concussion at the same time. Maybe they injured their jaw at the same time. If you have enough of a blow, you will have these types of problems. So there's a great overlap between what goes on. Now, certainly as a therapist, I can't diagnose someone with a concussion, but I can steer them on the right way by doing some intake. So besides the rehab checklist and besides the TMJ questionnaire, I want to remind you that you have some tools at your disposal that you can start looking at things differently. You have a dynamic gait index. That's not used just for old people. You have balance tests that you can use. You can do a quick balance vision check by talking to someone and saying, stand on one foot, stand on the other foot, open your eyes, close your eyes. You can get a little eye chart and just get an idea of what they can see and what they can't. And so the diagnosis becomes important, and is usually done by an optometrist or an ophthalmologist. But then, of course, we're faced with the rehabilitation. So I'm going to get back to this word called pain management, and I told you I never use the word pain, because right away now it's symptom management. I may have an aching feeling or a sharp feeling in my neck over the course of the day, and how do I manage that versus my chronic back pain, where I have to swim 3 times a week and I use my TENS unit. Personally, I do. So I'm following a program 24/7. But what if you have someone who has a concussion and or another reason for their symptoms as well as the pain problem? Well, they too need a symptom management program. Maybe they have to avoid crowds. They have to avoid areas that have a lot of light, a lot of noise, a lot of light, a lot of distraction, so that, and they may not realize what they're doing until you start asking some questions. So the question I now ask the guy that comes in 3 years post-trauma is, do you have problems when you walk into a busy store? How does that make you feel? When you walk into Walmart or Costco, how does that make you feel? Are you anxious? Do you have any problems driving? And we have to realize that that's a whole other area that someone can pick up as a research topic, is driver's anxiety. Is it really driver's anxiety, or is it spatial awareness? Maybe I can't see the edges of where the cars are or are moving fast enough. I can't really tell how fast they're moving. And then if my neck hurts as well, then that's an added problem. And one of the key questions I ask is, are you reading as much as you did before the accident? And they look at me and say, well, physiotherapists don't usually ask that question. But if you're not reading it, and not that everybody reads as much as we do, but nonetheless reading or sitting behind a computer or watching television, remember there's a lot of movement. Everything is movement, movement, movement. And very often the eye problem, the visual problems become blurriness and fuzziness, and the letters move up and down, and the sentences don't seem to go together. And we have to start asking those types of questions. So that's my message, is to really say to yourself, when someone is not improving, I'm all for Greg saying you must listen very carefully, but the listening may also need some specific questions about their functional day-to-day, and make that integrated into the rehab system. The challenge for us, there's a lot of students and a lot of young people in this room, so if you want some research ideas, speak to me. I think I have a whole bunch of research ideas that I'm not going to be doing, but we still have to answer that. Because we do need evidence-based, we need guidelines, we need to help people start. And sometimes when a patient with a persistent pain problem walks in, we really don't know where to start. So we really have to learn where to start. So final note is to remember that person with persistent pain started off as an acutely injured person. All right, for the most part I'm talking about trauma. So looking at, and it didn't come, again, I hope we've gone past that theory of people not coping well or labeling them as psychologically distressed, not to suggest that there aren't some who are. But generally, I would think that most people are still trying hard to get better. So we have to be careful not to label people and say, if if that person started off, even if I'm seeing them 3 years post-trauma, I could have been seeing them day one post-trauma, or maybe a week or two post-trauma. What signs and symptoms would I be able to pick up? Now that we're starting to look at red flags, yellow flags for pain is one issue, but the post-concussion issue is another one, and looking at, this idea of what exactly happened with the mechanism of injury. Maybe you didn't hit your head, but maybe you really got shook up, or maybe for a moment you really weren't sure where you were. That could all mean that they've had some type of brain trauma, and we're not very good at diagnosing it just yet. So I would encourage you to watch your acutely injured patients very carefully and make sure that symptoms resolve before you say they're okay, go back to work. Jackie was talking about sports guidelines and return to play. Well, we're going to have the same thing with return to work. I mean, it's the same basic issues. We may not realize that maybe it's not just the physical dimension of the work, but maybe there are other issues affecting somebody being able to return to work. Okay? So call me if you need some ideas, all right? Because we need a lot of evidence-based in this area. Thank you very much. Okay.